Welcome to the Epidemiology and Prevention of Vaccine Preventable Diseases webinar series. I'm Andrew Kroger. I'm a medical officer in the Immunization Services Division of the National Center for Immunization and Respiratory Diseases, or NCIRD, at the CDC, and I'll be the moderator for today's session. To participate in today's program, all you will need is an internet connection. Here are our learning objectives. At the conclusion of this session, the participant will be able to describe the different forms of immunity, describe the different types of vaccines. For each vaccine preventable disease, identify those for whom routine immunization is recommended. For each vaccine preventable disease, describe characteristics of the vaccine used to prevent the disease. Describe an emerging immunization issue. Locate resources relevant to current immunization practice. And implement disease detection and prevention healthcare services. For example, smoking cessation, weight reduction, diabetes screening, blood pressure screening, immunization services to prevent health problems and maintain health. Today is July 6, 2016, and on the agenda is the Epidemiology and Prevention of Vaccine Preventable Diseases Pink Book, specifically the chapter Immunization Strategies for Healthcare Providers, or Immunization Strategies for short. This topic will be presented by Dr. Raymond Strickus, Medical Officer and Team Lead in for the Education Team in the Communication and Education Branch, or CEB, of the Immunization Services Division, ISD, of the National Center for Immunization and Respiratory Diseases, NCIRD. Continuing education, or CE credit, is available only through the CDC ATSDR Training and Continuing Education Online System at www.2a.cdc.gov/TCE online. If you are watching this version live, CE credit for the session will expire on August 8, 2016. If you are watching the Enduring Archive version, CE credit for the session expires on June 1, 2018. When obtaining CE, you'll be required to provide a verification code. Watch and listen for the verification code during the course. Verification codes will not be given outside of this presentation. CDC, our planners, and our presenters wish to disclose they have no financial interests or other relationships with the manufacturers of commercial products, suppliers of commercial services, or commercial supporters. Presentations will not include any discussion of the unlabeled use of a product or a product under investigational use. CDC does not accept any commercial support. A list of resources for immunization strategies will be available, and the web page is www.cdc.gov/vaccines/pinkbook/pb5.asp. If you have a question during this presentation and related to this presentation, please type your question into the QA pod. I will collect these questions during the presentation, and then we will address them during the question and answer period, which will follow Dr. Strickus' presentation. We are joined by Hanan Awad, a public health advisor and AFEX lead in our division's program.
Thank you, Dr. Kroger. Today we'll talk about strategies to improve immunization coverage, or vaccine uptake as some call it. An important component of immunization providers' practice is ensuring that vaccines reach all the people who need them. While attention to appropriate administration of vaccines is essential, it cannot be assumed that these vaccines are being given to every person at the recommended age. Immunization levels in the United States are high, but gaps still exist. We still see outbreaks of vaccine-preventable diseases such as recent measles, mumps, and pertussis outbreaks, and providers can do much to maintain or increase immunization rates among patients in their practice. This table, which we have presented before in this webinar series, lists the average annual morbidity in the 20th century for a variety of vaccine-preventable diseases that were calculated in 2007. These are in the second column, and then lists the number of cases in the year 2014 for these same diseases in the third column. In the far right-hand column is displayed the percent decrease in disease morbidity. The table that's in your Pink Book Safety chapter has slightly different numbers because the current years, 2006 and 2014, instead of 2014, And also the comparison morbidity data from the 20th century is not an average over that period of time, but reflects data from a specific point prior to 2007. The important point, though, is that the right-hand column marks these data as a success story for vaccines with 96% or greater reduction in all of these diseases, except pertussis, which has dropped by 86%. In 2014, the national vaccination coverage data among children aged 19 through 35 months with the combined vaccine series of the vaccines listed at the bottom of the slide was 71.6%. Similar in coverage to 2013 with a slight improvement. We should have 2015 data soon, and we will publish it by about September of this year. These data were published from the National Immunization Survey in the August 28, 2015 Morbidity Mortality Weekly Report, or MMWR. Data from the 2014 National Immunization Survey for teens shows some progress has been made in HPV vaccination coverage in girls since 2012. That's demonstrated in the dotted lines in the middle of the graph. From 2007 to 2011, vaccination coverage significantly increased each year for all doses of HPV vaccine, but the rates lagged behind those for Tdap and meningococcal conjugate vaccine, which are the two lines at the top of the graph. HPV coverage increased between 2013 and 2014 from 56.7 to 60%, the third line down with small dots, for one or more HPV doses among females 13 through 17 years of age, and from 33.6% to 41.7% for one or more HPV doses among males, the line with one bar followed by two dots. Completion of the 3-dose HPV series increased since 2013, but is still low at 39.7% for females and 21.6% for males. Also, coverage varied by state and local jurisdiction. The dotted vertical line at 2013 indicates a revised adequate provider data, or APD definition, which makes the data collected prior to 2013 not directly comparable to those in 2013 and 2014. The strong coverage rates for Tdap meningococcal vaccines, again in the top two lines in the graph, demonstrate that most preteens and teens are getting to their provider for these two vaccines, but opportunities are still being missed for HPV vaccination. Influenza vaccination coverage among those 19 years of age and older was 39.6% during 2011-12, 42.8% during 2012-13, and 43.2% during the 2013-2014 influenza season. Coverage significantly increased from the 2011-12 season to 2013 and 14, but coverage during all seasons was well below the Healthy People 2020 target of 70%. Influenza vaccination among healthcare personnel, abbreviated HCP here, those aged 19 and older, was 61.5% in 2011-12, 67% in 2012-13, and 65.4% in 2013-14. Coverage did not increase significantly from 2011-12 to 2013-14, and coverage during all seasons was well below the Healthy People 2020 target you see there at 90%. Pneumococcal vaccination coverage among those 19 to 64 years with high-risk conditions was 20% in 2012, 21.2% in 2013, and 20.3% in 2014. During all of these years, you can see it's well below the Healthy People 2020 target of 60%. Pneumococcal vaccination coverage among persons 65 years and older was 59.9% in 2012, 59.7% in 2013, and 61.3% in 2014. While edging upwards, coverage in all years was well below the Healthy People 2020 target of 90%. Herpes zoster vaccination coverage among those 60 years and older, the recommended age by ACIP, was 20.1% in 2012, 24.2% in 2013, and 27.9% in 2014. Coverage significantly increased from year to year, and it approached the modest Healthy People 2020 target of 30%. The zoster estimate for non-Hispanic whites of 32% exceeded the Healthy People 2020 target, but again, this is a modest target. Moving to tetanus vaccination, the proportion of adults who received a tetanus vaccination during the past 10 years was 62.6% for those aged 19 to 49 years, 64.7% for those aged 50 to 64 years, and 57.7% for those aged 65 years and older. Overall, tetanus coverage really has not increased since 2013. Reported Tdap coverage among persons aged 19 years and older was 20.1%, a 2.9 percentage point increase compared with the 2013 estimate. Tdap vaccination of adults who have close contact with infants less than 1 year, such as parents, grandparents, child care providers, and healthcare personnel, can reduce the risk for transmitting pertussis to unprotected infants. Tdap coverage of such adults aged 19 and older was 32% in 2014, similar to the 2013 estimate. Tdap vaccination in the bottom line between 2005 and 2014 was 42.1%, similar to the 2013 estimate. So we have varying immunization coverage levels across vaccines and populations, many of which can and should be improved. Many strategies have been used to increase immunization coverage. Some, such as school entry laws, have effectively increased demand for vaccines, but the effectiveness of other strategies, such as advertising, is less well documented. Some proven strategies, such as reducing costs, linking immunization to women, infants, and children or WIC services, and home visits by medical personnel, are well suited to increasing rates among specific populations, such as persons with low access to immunization services. One key to a successful strategy to increase immunization is matching the proposed solution to the current problem. Although a combination of strategies directed at both providers and the public is necessary for increasing and maintaining high immunization rates, this program focuses on immunization strategies for healthcare practices and providers. CDC, through state and other awardees, administers a program designed to move healthcare personnel to being knowledgeable, concerned, and motivated to change their immunization practices and become capable of sustaining new behaviors. The acronym used for this approach is AFIX, Assessment of the Immunization Coverage of Public and Private Providers, Feedback of Diagnostic Information to Improve Service Delivery, Incentives to Motivate Providers to Change Immunization Practices or Recognition of Improved or High Performance, and finally, Exchange of Information among Providers. First conceived by the Georgia Division of Public Health, AFIX is now being used nationwide with both public and private immunization providers and is recommended by governmental and non-governmental vaccine programs and medical professional societies. First, AFIX focuses on outcomes. It starts with an assessment, producing an estimate of immunization coverage levels in a provider's office or clinical setting, and these data help to identify specific actions to take to remedy deficiencies. And outcomes are easily measurable, that is, their immunization coverage outcomes. Second, AFIX focuses on providers, those who are key to increasing immunization rates. AFIX requires no governmental policy changes, nor does it attempt to persuade clients to be vaccinated, but instead focuses on changing healthcare provider behavior. Third, AFIX, when used successfully, is a unique blend of advanced technology and personal interaction. Much of the AFIX process can be done electronically, increasing speed and accuracy of assessment and feedback, and streamlining reporting. However, the personal skills of the assessor and that person's ability to establish rapport with and motivate a provider and their staff are critical to achieving lasting results. Assessment refers to the evaluation of medical records to ascertain the immunization rate for a defined group of patients, as well as to provide targeted diagnosis for improvement. This step is essential because several studies have documented that most healthcare providers, while supportive of immunization, did not have an accurate perception of their own practices' immunization rates. Pediatricians in these studies greatly overestimated the proportion of fully immunized children in their practices. Assessment increases awareness of a provider's actual situation and provides a basis for subsequent actions by provider staff. CDC has developed a software program, the Comprehensive Clinic Assessment Software Application, or COCASA for short, which enables assessment to be done electronically, is flexible enough to accommodate whatever assessment parameters are desired, and provides results that can be printed immediately. I will describe COCASA in more detail later. Feedback is informing immunization providers about their performance in delivering one or more vaccines to a defined client population. The work of assessment is of no use unless the results are fed back to persons who can make a change. Assessment, together with feedback, creates the awareness necessary for behavior change and improved performance. Feedback usually includes the immunization program representative meeting with provider staff and discussing the results of the assessment to determine the next steps to be taken. This may take 1 to 2 visits. If COCASA has been used, the summary report that is generated can identify specific subsets of patients, such as those who have not completed a vaccination series because of a missed opportunity, and found in substantial numbers. These data can provide clues to which changes in the provider's practice would be most effective. The personal element of feedback is also critical to its success. An involved reviewer who's committed to the AFIX process, who addresses deficiencies precisely without judgment, and who respects the confidentiality of the data and the efforts of the provider, will be likely to gain the trust of providers and motivate them to increase immunization rates in the practice. An incentive is something that incites one to action or effort. Incentives are built into the AFIX process, recognizing the immunization providers, like most everyone else, will accomplish a desired task more successfully if motivated to do so. The assessment and feedback components are not intended to be done in isolation. Providers may have sufficient data about their practice's immunization rates, but they must recognize high immunization coverage as a desirable goal and be motivated to achieve it. Incentives vary. No one thing will be effective for every provider, and a single provider may need different types of motivation at different stages of progress. Small tokens of appreciation and providing resource materials at meetings have helped providers approach their task positively and create an atmosphere of teamwork. Longer-term goals must be considered as well. Because the effort to raise immunization rates may involve an increase in duties for staff, offering assistance in reviewing records or sending reminder notices might more directly address a provider's needs. Incentives pose a challenge to the creativity of the program representative, but also offer the opportunity to try new ideas. Finally, incentives are opportunities for partnerships and collaboration. Professional organizations or businesses and other groups have been solicited to publicize the immunization efforts in a newsletter or provide funding for other rewards for provider staff. Exchange of information is a follow-up process with providers. It usually takes place 3 to 6 months from the feedback date. This allows one to rerun assessment coverage data and see if there has been improvement, and discuss progress of implementing quality improvement action steps discussed during feedback. It also helps coordinate resources and efforts in the practice. Private providers now vaccinate nearly 80% of children in the United States. Many of these providers participate in the Vaccines for Children, or VFC, program, a federal program whereby funding is provided for state and other immunization programs to purchase vaccines and make them available at no cost to children who meet income eligibility requirements. CDC launched an initiative in the year 2000 to link some AFIX and VFC activities and incorporate AFIX activities during VFC provider site visits in an attempt to avoid duplication of staff time and effort. However, reported concerns with proper storage and handling of vaccine led the federal VFC program to revise this approach. Beginning in 2013, VFC program staff are encouraged to perform VFC compliant visits separate from the AFIX visit to focus on the core components of each program, including the assessment of and provider training related to proper vaccine storage practices. VFC programs may choose to continue to combine these program efforts if the state has a robust immunization information, or IIS, system that assists with performing the AFIX assessment portion of the visits. VFC serves more than 40,000 private provider sites, and every state participates in the program. VFC provider site visits are conducted to review compliance with federal program requirements, including VFC eligibility screening, and to evaluate vaccine storage and handling procedures. I mentioned earlier CDC has developed a software program titled Comprehensive Clinic Assessment Software Application, or COCASA, to enable electronic entry of AFIX and VFC site visit data. COCASA, first released in December 2005, is an update of previous versions of CASA. Using COCASA, a reviewer enters appropriate basic information about an individual provider and conducts an assessment of patient records. The user also has the option to record AFIX visit outcomes and VFC site visit information. COCASA can provide immediate results of the assessment, supplying the reviewer with the information needed for use in the feedback session, and noting areas that need further follow-up. COCASA reports provide estimates of immunization coverage levels and potential reasons for the coverage deficiencies, such as missed opportunities for immunization and patients who did not return to finish the immunization series. The program can generate reports on subsets of patients. Data from an immunization registry or IIS or patient management system can be imported into COCASA, and data collected during the visit can be exported for further analysis. Additional resources available for AFIX include the AFIX Guide to the Core Elements for Training and Implementation document. This document generalizes the AFIX process so it can be applied to any age group. When differences between populations do exist with respect to the AFIX process, this document clearly identifies the difference and provides helpful strategies for modifying the AFIX methods. The COCASA and AFIX websites are at the bottom of this slide, where you can find more information about them. Although a substantial portion of this presentation and the related Pink Book chapter are devoted to AFIX, certain other strategies for improvement of immunization levels deserve emphasis. These are complementary to AFIX. Their adoption will support the goals of AFIX, that is, raising immunization coverage levels, and will facilitate the AFIX process and ensure a favorable outcome of an assessment. And these include record keeping, Immunization Information Systems, or IIS, recommendations and reinforcement by providers, reminder and recall to patients, reminder and recall to providers, reduction of missed opportunities, and reduction of barriers to immunization. Immunization records should meet all applicable legal requirements as well as requirements of any specific program such as VFC in which the provider participates. These records should be available for inspection by an AFIX or VFC representative and should be easy to interpret by anyone examining the record. Immunization records must be accurate. The active medical records must reflect which patients are actually in the practice. Charts of persons who have moved or are obtaining services elsewhere should be clearly marked accordingly or removed. Records should be kept up to date as new immunizations are administered, and all information regarding the vaccine and its administration should be complete. Because patients often receive vaccines at more than one provider office, communication between sites, such as schools and pharmacies, is necessary for maintaining complete and accurate immunization records. Existing immunization data should be put into the IIS and help providers keep records up to date, and we will see this on the next slide. Many record-keeping tasks, as well as patient reminder and recall activities, can be greatly simplified by participation in a population-based immunization information system, again, abbreviated IIS, and sometimes also called an immunization registry. An IIS is a computerized information system that contains information about the immunization status of each person, adults and children, in a given geographic area. An IIS provides a single data source for all community immunization providers, enabling access to records of persons receiving vaccinations at multiple providers. Nearly all states have an IIS, which have been active for a number of years. The Task Force on Community Preventive Services recommends immunization information systems on the basis of strong evidence of effectiveness in increasing vaccination rates. The task force concluded IIS are directly related to increasing vaccination rates through their capabilities to create or support effective interventions such as client reminder recall systems, provider assessment and feedback, and provider reminders. IIS also generate and evaluate public health responses to outbreaks of vaccine-preventable disease, facilitate vaccine management and accountability, determine client vaccination status for decisions made by clinicians, health departments, and schools, and IIS also aids surveillance and investigations on vaccination rates, missed vaccination opportunities, invalid dose administration, and disparities in vaccination coverage. A goal of the department Let me go back one slide. A goal of the Department of Health and Human Services program, Healthy People 2020, is to increase to 95% the proportion of children younger than 6 years of age who participate in fully operational, population-based immunization registries, or IIS. In 2014, approximately 88% of children in this age group met this participation goal, defined as having 2 or more doses of vaccine recorded in an IIS. Federal, state, and local public health agencies are continuing their efforts to improve the registries themselves and to increase participation by immunization providers. The recommendation of a healthcare provider is a powerful motivator for patients to comply with vaccine recommendations. Parents of children are likely to follow vaccine recommendations of the child's doctor, and adults who were initially reluctant were more likely to receive an influenza vaccination when the healthcare provider's opinion of the vaccine was positive. It is important for patients to have the next appointment date in hand at the time they leave the provider's office. An additional reminder strategy is to link the timing of the return visit to some calendar event, such as the child or patient's birthday or an upcoming holiday. Even with written schedules or reminders, a verbal encouragement reminder can be an incentive for patients completing the immunization series and can ultimately result in higher coverage levels. Patient reminders and recall messages are messages to patients or their parents stating that recommended immunizations are due soon, that is, reminders, or past due, and these are recall messages. Both reminders and recall messages have been found to be effective in increasing attendance at clinics and improving vaccination rates in various settings. The image here is part of an immunization reminder card developed by the Arizona Partnership for Immunization. Cost is sometimes thought to be a barrier to the implementation of a reminder recall system. However, a range of options is available, from computer-generated telephone calls and letters to a card file box with weekly dividers for phone calls, and these can be adapted to the needs of the provider. The specific type of system is not directly related to its effectiveness. The benefits of having any system can extend beyond immunizations to other preventive services and increase the use of other recommended screenings. Both the standards for child and adolescent immunization practices and the standards for adult immunization practices call upon providers to develop and implement aggressive tracking systems that will both remind persons of upcoming immunizations and recall those who are overdue. The National Center for Immunization and Respiratory Diseases at CDC provides state and local health departments with ongoing technical support to assist them in implementing reminder and recall systems in public and private provider sites. Providers can create reminder and recall systems that help them remember which patients' routine immunizations are due soon or past due. Provider reminder recall is different from feedback, in which the provider receives a message about overall immunization levels for a group of clients. Examples of reminder recall messages are a computer-generated list that notifies a provider of the children to be seen that clinic session whose vaccinations are past due, a stamp with a message such as no pneumococcal vaccine on record that a receptionist or nurse can put on the chart of a person aged 65 years or older, an immunization due clip that a nurse attaches to the chart of an adolescent who's not had HPV vaccine, and an electronic reminder which appears when the providers access an electronic medical record. Reminder systems will vary according to the needs of the provider. In addition to raising immunization rates in the practice, they will serve to heighten the awareness of staff members of the need to check the immunization status of their patients. A missed opportunity is a healthcare encounter in which a person is eligible to receive a vaccination but is not vaccinated completely. Missed opportunities occur in all settings in which immunizations are offered, whether primary care settings or others. Here we see a physician chasing after a patient who did not receive an indicated vaccine at a just concluded clinic visit. Missed opportunities for vaccination occur for several reasons. At the provider level, many nurses and physicians avoid simultaneous administration of 4 or even 3 injectable vaccines. Frequently stated reasons have included concern about reduced immune response or adverse events, and parental objection. These concerns are not supported by scientific data. Providers also may be unaware that a patient is in need of vaccination, especially if the immunization record is not available at the visit, or they may follow invalid contraindications. Some of the reasons for missed opportunities relate to larger systems, such as a clinic that has a policy of not vaccinating at any visit except well child care or not vaccinating siblings. Other reasons relate to large institutional bureaucratic regulations, such as state insurance laws that deny reimbursement if a vaccine is given during an acute care visit. The degree of difficulty in eliminating the missed opportunity may vary directly with the size of the system that has to be changed. Several studies have shown that eliminating missed opportunities could increase vaccination coverage by up to 20%. Strategies designed to prevent missed opportunities have taken many forms, used alone or in combination. And examples include the following. Standing orders. These are protocols whereby non-physician immunization personnel may vaccinate clients without direct physician involvement at the time of the immunization. Standing orders are implemented in settings such as clinics, hospitals, nursing homes, and pharmacies. Provider education. Anyone responsible for administering immunization should be knowledgeable about principles of vaccination and vaccination scheduling to the extent required for their position. Numerous educational materials in a variety of formats are available from CDC, the Immunization Action Coalition, as well as state and local health departments, hospitals, and professional organizations. Incorporating some ethics principles such as assessment and feedback into a provider education program might have a greater effect on provider behavior than an education effort aimed only at increasing knowledge. Provider reminder and recall systems. I mentioned these systems earlier in the presentation. These reminder systems, while effective in increasing immunization levels, can also help avoiding missed opportunities if they are a component of other practices directed towards this goal. For example, if a reminder system is used consistently and staff members are knowledgeable of vaccination opportunities and valid contraindications, the system can be an additional aid in promoting appropriate immunization practices. Obstacles to vaccination of patients may exist within the practice setting, sometimes unknown to the provider. Barriers to immunization may be physical or psychological. Physical barriers might be such things as inconvenient clinic hours for working parents or patients, long waits at the clinic, or the distance patients must travel to the clinical setting. Providers should be encouraged to determine the needs of their specific patient population and take steps such as extending clinic hours or providing some specific immunization clinics to address these obstacles to immunization. Cost is also a barrier to immunization for many patients. In addition to evaluating their fee schedule for possible adjustments, providers should be knowledgeable about such programs as Vaccines for Children and the State Children's Health Insurance Program and the provisions specific to their state. Enrollment as a VFC provider is recommended for those with eligible children in their practice. Psychological barriers to healthcare are often more subtle, but may be just as important. Unpleasant experiences, such as fear of immunizations, being criticized for previously missed appointments, or difficulty leaving work for a clinic appointment, may lead clients to postpone receiving needed vaccinations. Concerns about vaccination safety are also preventing some parents and adults from having their children or themselves immunized. Overcoming such barriers calls for both knowledge and interpersonal skills on the part of the provider. The provider should have knowledge of vaccines and updated recommendations, as well as reliable sources to direct patients to find accurate information. These attributes can lead to the smiling faces from all concerned as depicted on the lower image on the slide. There are numerous resources describing immunization strategies and their implementation. I've cited many on specific strategies slide in this presentation, and they're also cited in the Pink Book. In addition, CDC has developed tools for conversations with parents and information about the Vaccines for Children program that you'll find useful. Also, the Task Force on Community Preventive Services, an advisor group to CDC, has reviewed many strategies for most preventive services, including immunization, and their website is listed here. The task force has provided detailed reviews of the evidence behind the recommended strategies we have discussed today. As I said earlier, there are standards for pediatric and adult immunization practice promulgated by the National Vaccine Advisory Committee, which advises the Department of Health and Human Services about immunization policy issues. I trust you'll find these resources useful. Thank you for joining us today for this program on immunization strategy.
Thank you very much, Dr. Strickus. I'd now like to direct our viewers to the screen where you will see a resource pod which contains continuing education credit information, including the verification code for today's course. Please make note of this verification code as it will not be given outside of this presentation. So today's verification code is 2016-STRATS, that's STRATS, and this verification code applies to both the live program and the enduring program. I'll repeat the verification code, 2016-STRATS. So now I am happy to review some of the questions that we have received during this program. Please continue sending these to the pod. I'll remind listeners, if you have any questions related to the recent ACIP vote on cholera vaccine, meningococcal vaccine, and LAIV vaccine, we are not going to answer these questions today on this program. Please send them to the NIP info email address that you'll receive at the end of this program. And so, Dr. Strickus, we received a question which relates to the first slide that you showed where you compared current morbidity with the 20th century average morbidity. Is this data U.S. data or international data?
Yeah, thank you, Dr. Kroger. The data presented were for the United States. International data are available, but I think it's most relevant to talk about the data that are relevant to our clients and our practices.
Okay, thank you. We have another question here. Why is the Healthy People 2020 target, you showed a list of targets for zoster vaccine at 30%? It seems kind of low for a target.
I agree with you and the inquirer that the target is low, and my understanding, although I did not set the target, didn't work on that part of the Healthy People 2020 program, was that because zoster is a new vaccine and introducing vaccines for adults is a challenging prospect, somewhat different than introducing new vaccines for children, hence the targets for childhood vaccines are higher. The zoster target was set purposely low so there'd be a reasonable opportunity to achieve it. And I expect that it appears it will be achieved, and the target will be raised substantially for the year 2030, and those deliberations are ongoing now. But one likes to have achievable targets, and I think that was the idea given the challenges in adult immunization.
Okay, that makes sense. We have another question. If all pregnant females are to receive Tdap with each pregnancy, even if 10 years have not passed, how do we get insurance companies to pay for that?
I can only say that my understanding is current law says through the Affordable Care Act and other legislation is that recommendations from the ACIP are to be adopted by insurance plans that are part of usual care, with a very small number of exceptions. So that's something we'll explore further with our policy folks and try to offer an enhanced question or enhanced answer to your question in writing on our website. But it should be covered if it's an ACIP recommendation within 1 year of the recommendation being made, and that recommendation was made in 2012. So we'll have to look into that further for you.
Okay, very good. Here's another question. In terms of Medicare, this question reads, why does Medicare not cover Tdap, only TD?
Again, we'll check with our Medicare colleagues to make sure we have the complete information. My understanding is Medicare was primarily set up as a treatment program, and there are very few preventive measures that are covered by it, including vaccines. And the only vaccines that are routinely covered are influenza, pneumococcal vaccines, and these required special acts of Congress to be included. Tetanus toxoid alone for wound prevention prophylaxis, and hepatitis B vaccination, but only for high-risk patients such as those on hemodialysis. All other vaccines are usually covered, but they're covered under not under Part B Medicare, but Part D as in David Medicare. And we'll check and see if Tdap is covered. I believe it is, as is zoster vaccine covered for Medicare beneficiaries, but in a different part of the Medicare program.
Yeah, I think it's a B versus D issue. I think it's okay. Thank you. I have a question now for Hanan Awad. How on the COCASA program, how is COCASA able to determine missed opportunities?
Thank you for the question. So when using COCASA, which is a desktop application and it's a free tool to be used by anybody, in COCASA, what happens is that the assessors collect a number of patient records from the provider office, and this number is usually between 50 and 200 records. And so all this patient information is entered into COCASA to assess coverage and missed opportunities. And the COCASA can hold all the information for all their provider office visits as well as any immunization only visits. And so we're able to assess missed opportunities in one of several ways. It can be assessed based on the last patient visit to that provider. It can be assessed based on any visit to the provider office, and it can also be assessed based on vaccination only visits to providers. So you select the strategy you want to run the missed opportunities based on. So for example, and then we look at the minimum age and minimum interval recommendations by ACIP. And so for example, if we select missed opportunities based on the last vaccination visit, and we're assessing a group of kids in the 13 to 17 age range, because AFIC serves children and adolescents, all the age groups covered by VFC. So if we are assessing for HPV, MCV, and Tdap, based on the last vaccination visit, if the kids received 2 of the vaccines, so for example, if they received the meningococcal and the Tdap but did not receive the HPV, then they would have, COCASA will calculate a missed opportunity for the HPV. And there's an algorithm on our website that shows the exact calculations on how this takes place. And we could provide those as part of our resources after the call.
Okay, thank you very much. Great answer. We have a question here about clinic policies. I guess some clinics have policies not to vaccinate siblings. I don't know if there's, you can speak to that as a missed opportunity or potential solutions, or.
Yeah, this Dr. Strikas, I mentioned that in the discussion or the presentation today, and I'm not sure why people would consider that a contraindication to vaccinate one sibling and then not the other. It may be whether it's concern about live vaccine transmission, which we don't think MMR or varicella vaccines are transmissible, or the reason is unclear, but it's not a valid contraindication. So I've not heard that it come up very often, but it has come up occasionally, and there are no good reasons to avoid vaccinating one sibling versus the other, unless there was an immunocompromised sibling who was severely immunosuppressed, though usually that sibling won't be at home, and then you're asked to not give live attenuated influenza vaccine to the healthy sibling. So it's a fuzzy thing, and it's not entirely clear why some people have been concerned about it.
Okay. Thank you. We have another question in regards for immunizing adults. If an adult recalls having vaccinations as a child but has no proof of immunity, are there recommendations to do titers or to reimmunize?
Yeah, and I will probably ask you, Dr. Kroger, as one of the authors of the General Recommendations on Immunization, to make sure I don't omit something. But what we've said is that we can reliably take the history of an adult for influenza vaccination in the recent past. Most people recall they've had or not had influenza vaccination within the past year. And for pneumococcal vaccination, this recommendation stems back to when only pneumococcal polysaccharide vaccine was recommended for older adults. This may get more complex as we now recommend 2 different pneumococcal vaccines for older adults, but we still have that recommendation in place. For any other vaccine an adult reports, one would want to get records, and if the records are not available, you cannot conclude the adult has been immunized. So then the options are to revaccinate. For some vaccines, one might be able to do serology, such as for varicella. Now, for one exception to that is for adults 60 years of age or older, um, we don't recommend you need to do a serology to see if they've had varicella in the past. You can just give them the zoster vaccine because the vast majority of adults have had varicella. So that's another one where at that age you would just go ahead and give them zoster vaccine. But for other vaccines, and this is particularly commonly comes up with healthcare personnel, if they don't have records of hepatitis B vaccine, MMR, or varicella as examples, one can either just vaccinate them or one could do a titer, depending on the policies and resources available to the clinical setting. Dr. Kroger, if you want to add to that?
No, I think you've kind of covered all of the different vaccines. Usually in the post-vaccination context, where there's some remembrance of having had a vaccine. So we're talking about post-vaccination. You really, but you have no evidence, and you need to have evidence. You really don't want to bother with the serology. You could just revaccinate to make sure you establish that evidence of immunity. So that sounds good.
Thank you.
So okay, we have another question here about COCASA. When will COCASA be updated to accept HPV-9 as being administered in COCASA reports? As of now, it's not picking it up. Hanan?
I want to recommend downloading the latest version of COCASA from the website because it should be picking up HPV-9. But if there are issues around that, please send it to the NIP COCASA help desk so we can figure out if it's a bug or what's going on there. But to my knowledge, HPV-9 has been added to COCASA.
Okay, thank you. Dr. Strikas, we don't really have any questions coming in right now, but here's a question that we receive commonly. As far as the various strategies, how effective are the various strategies at increasing vaccine coverage, and do they vary in effectiveness between children and adults?
Yeah, there's some variation, and the details of this are described if one goes to communityguide.org is a website for the Community Guide for Preventive Services, and I'll recite some data, a part of which I've mentioned briefly, but there's more here. Home visits, you see an average increase if you do routine vaccination assessment and vaccination for people receiving home visits, about 10%, similar across populations. Reducing costs, about a 22% increase in coverage depending on the study, but similar across settings. Vaccination in schools and child care centers, obviously mostly limited to children and adolescents, a 47% increase in coverage. In WIC settings, more modest, 10%. Client incentives, nominal cash or gift cards, an 8.5% increase. Reminder recall for clients, a 6% increase, similar in children and adults. Standing orders, there's a wide range with an average of about 28%, similar in children and adults. There are some studies that cite much higher figures in standing orders, usually in practice that had low coverage for vaccinations such as influenza or pneumococcal vaccines in adults. So those are some examples, but I commend for you all, and we'll put it on the resource website. It was in the slides, the Community Guide's website for more details.
Okay, thank you. We have a question here about learning how to use COCASA. It's downloaded, but they're not quite sure how to use it. Hanan, can you explain a bit about how to learn to use COCASA?
So along with COCASA, we usually have a user guide to kind of help teach how to use COCASA. Unfortunately, the user guide has not been updated for this last release. So I encourage you to either email or contact the help desk, and the help desk person can walk you through how to use it and how to understand the reports and the information in COCASA. And it's the email is nipcocasa@cdc.gov. And there's also a phone number on the COCASA website to contact if you have questions, but I know the help desk person would be more than happy to walk them through the use of the tool.
Okay, thank you.
And, while we get a chance to update the user guide, which, yeah, thank you.
Thank you. Dr. Strix, there's a question about shingles vaccine. Are they looking at lowering the age of getting the shingles vaccine?
ACIP reviewed the issue and published a statement with no change in its recommendations several years ago. that while the vaccine is licensed for persons 50 years of age or older, the ACIP maintains that 60 years of age or older is more appropriate because the risk of zoster is substantially less in people 50 to 59 years. It goes up fairly dramatically beginning about age 60. Also, this was written some years ago where there had been some supply disruptions of zoster vaccine, and there was concern at the time to make sure supply was adequate for people at higher risk of zoster. And the last issue that is still being researched is the duration of protection after one dose of zoster vaccine is not clearly defined. It's a subject of continuing research. Protection seems to last for 8 to 10 years. How much longer than that it lasts is still being studied. And so if one vaccinates at a younger age, will one need a booster dose sooner or not? And that's unclear, but given the uncertainty of that issue, of the possibility of needing booster doses in persons who receive one dose at 60 or older, the ACIP concluded they should leave the recommendation for persons to receive the vaccine at 60 or greater, but not any younger than that.
Okay, thank you. There's a quick follow-up question about zoster vaccine. Would a dose of zoster vaccine be useful if someone has already had zoster disease? Or
yeah, my understanding of the data are that up to 10% of people who've had zoster once are at risk for may develop a second case, and therefore receiving the vaccine. And our experts in zoster say the vaccine might be given a year or so after the episode of zoster to promote. They have the best chance of promoting T-cell immunity, which is what you want. And we are hopeful that would prevent a subsequent second case in those people at increased risk for it. So it is recommended that even if a person's had zoster, you wait about a year and then you could vaccinate them with the currently available zoster vaccine.
Okay, great. Thank you. Here's another common question we receive. In terms of vaccine requirements, how well do they work in a healthcare setting, such as requirements for influenza vaccination in hospitals?
Yeah, so the literature suggests that if one just recommends the healthcare personnel be vaccinated and makes vaccine available to employee health clinic or somewhere in the healthcare facility, you'll get vaccination uptake of about 50 to 60%, maybe a little higher depending on the setting. If there's an aggressive promotion of vaccination where one is actively counting persons vaccinated, having people sign a declination form, acknowledging they decline and that they understand they may be excluded from work if there's an influenza outbreak in the institution and or have to wear a mask during the time when influenza circulates in the community, that at least some facilities have gotten vaccination coverage up to near 90%. Mandatory vaccination, that is with only medical exemptions allowed, will get coverage to 98%. Now, mandatory vaccination is something that is each institution should take into account whether that is something they wish to pursue. It takes a lot of work to work with healthcare personnel to have them understand the rationale why that should be done and to have them accept it. And typically places that adopt a mandatory vaccination program have done a lot of spade work ahead of time with their healthcare personnel to explain the need for this. And do a lot of education about the benefits of vaccination, realizing influenza vaccine is only about 60% effective preventing influenza-related illness, but the benefits both to the healthcare worker and to the patients. And there are a number of facilities that have received those high levels of coverage, and these are documented in part on the Influenza Immunization Action Coalition's honor roll of institutions that have gotten very high coverage. If you go to immunize.org, you can look at their honor roll of those organizations.
Okay, thank you. Great source there for information. How about a provider's recommendation as a strategy? How much difference does that make in increasing vaccination rates?
Estimates vary. Again, it's highly variable by study and how aggressively does a provider recommend things. But coverage, if we talk about influenza vaccination, will at least double, and in settings where there have been little effort with influenza vaccination, there have been even fivefold increases in coverage, but those are places with very low coverage to start with. So providers' recommendations do make a notable difference. That's why we encourage them as perhaps the first and foremost strategy is you've got to believe in the vaccines and recommend them strongly to your patients as appropriate.
Okay. And like, how much do these provider interventions cost?
Yeah, when I last reviewed the literature, and again, you can check some of this information on the Task Force for Preventive Services website. Standing orders will cost about $4 to $6 per patient in the clinical setting. Provider reminders have average, they can vary, $5 per patient. Immunization information systems are typically set up and run by state and sometimes local government. So the cost to the providers, which they'll have to estimate, is the time for data entry for the client and whatever that cost may be, and whether they can have data transferred from their information systems to the other information system is something I know that is an active area of research, but data entry is still usually required, so it depends on that cost. So those are some examples.
Okay, great. Thank you. Well, that's all the time we have for questions today. So now I will provide some continuing education credit information. You can go to the webpage, www.2a.cdc.gov/TCE online to obtain credit. Today's live CE event course number is WC2645-070616. I'll repeat it, WC2645-070616. That is today's date and differentiates this presentation from others in the series. CE credit for the live course will expire on August 8th, 2016. You can also search for the Enduring Archive course number, which is different. That course number is WD2645-070616. That CE credit expires June 1st, 2018. You'll also need the verification code, which is 2016-STRATS. This verification code applies to both the live program and the Enduring program. I'll repeat it, 2016-STRATS. For help with the online system, which is available between 8 a.m. through 4 p.m. Eastern Time, please dial 1-800-41-TRAIN. This corresponds to 1-800-418-7246, or you can email ce@cdc.gov. If you have additional questions that were not answered on today's program, you may email us at nipinfo@cdc.gov, and we'll try to respond to those as quickly as possible. We'll also post answers to questions that we didn't get to today that you may have sent in at www.cdc.gov/vaccines/ed/pinkbook pb5.asp. That's the same website that I mentioned earlier. You can also call immunization questions into us at 1-800-CDC-INFO. That corresponds to 1-800-232-4636 from 8 a.m. to 8 p.m. Eastern Time, Monday through Friday. Additional resources we have include the Pink Book, and the website for the Pink Book is www.cdc.gov/vaccines/pubs/pinkbook/index.html. It is also available online, or you can purchase a hard copy at the link for the Public Health Foundation Learning Resource Center. Our CDC vaccine homepage is cdc.gov/vaccines/default.htm. Our resource guide for healthcare personnel is entitled CDC Immunization Resources for You and Your Patients, and that is listed at www.cdc.gov/ed/downloads/imz-resources.pdf. Follow us on Twitter for immunization news, information, and resources for private and public healthcare personnel. That's at CDCIZ Learn on Twitter. So that concludes our program. I want to thank Dr. Raymond Strickus for the presentation today, covering this topic in great detail, and to Ray and Hanan Awad for answering all of your questions. Thank you very much, and have a great day from Atlanta. Goodbye.